Hi everyone, my name is Helia Khaledi. I'm a fourth year medical student at LF1, and the topic I'm going to be teaching today is regarding kidney pathology. I hope this clears out some concepts that you guys weren't sure of, and it just helps out round up your whole knowledge about kidney pathology. So first things first, we're first just gonna talk about the kidney itself and its different functions. So we know that the kidney is used to excrete waste products of metabolism, regulate body water and salt, maintain acid-base balance, and secrete many hormones and prostaglandins. And we can divide it into the four structures of glomeruli, tubules, interstitium, and blood vessels. Something particular about these structures is that some of them are more vulnerable to a specific type of injury than the others. So for example, the glomeruli, they're more vulnerable to immunological mediated diseases, but tubular and interstitium, these are more likely to be caused by toxic or infectious agents. And then some disorders, they also affect more than one structure. And the kidney has an interdependent structure in each part of it is dependent on other parts. So because of this, a lot of the times when damage to one part of the kidney, one component of the kidney affects another one or more. And then lastly, when we do have chronic kidney failure and it progresses to its worst stage, known as end-stage renal diseases, all four components that we mentioned are affected. Now, we'll go to clinical manifestations, of basic clinical manifestations of how kidney diseases look like, and then we'll go into more details about the different, the structures of the glomeruli and the different diseases and how they progress. But for now, the clinical manifestations, the two most ones are azotemia and uremia. Azotemia is the elevation of blood urea nitrogen and creatinine levels, and it usually reflects decreased glomerular filtration rate, which can be a consequence of intrinsic or extrarenal causes, right? And then we can later divide the azotemia into it being pre-renal or post-renal azotemia. There's also renal, but for pre-renal, it's usually encountered when there's hypoperfusion of the kidneys, usually due to reduced extracellular fluid volume. This decreases the GFR in the absence of the renal parenchymal damage and is usually reversible if the hypoperfusion is corrected in time. And then we have post-renal, which results when the urine outflow was obstructed. Relief of the obstruction corrects the azotemia. And renal is when the azotemia is caused by something in the kidney itself. And then uremia is just the consequence of azotemia, when azotemia becomes high enough for it to give clinical manifestations and biochemical abnormalities. This can be renal excretory functions are affected and metabolic and endocrine functions. Also GI, neuromuscular, cardiovascular, and many more organs can be involved. So the kidney, if it fails, it can be shown in other organs and other systems as well. Now we're gonna go talk about glomerular diseases in the next many slides actually. So before we do that, we first go through how the glomerulus looks as a whole. The glomerulus is a network of capillaries that it's invested by two layers of epithelium, and like every other organ, they're called the visceral and parietal epithelium. The visceral epithelium is composed of podocytes and it's part of the capillary wall, while the parietal epithelium, it encircles the Bowman space, which is the cavity in which the plasma collects in during filtration. Now, the glomerular capillary unit is composed of many different structures, and we like to call them, and they're the fenestrated endothelium, the glomerular basement membrane, which has a thick electron-dense central layer called the lamina densa, and two thinner electron-lucent peripheral layers called the lamina rara interna and the lamina rara externa. The glomerular basement membrane has collagen type 4, laminin, proteoglycans, fibronectin, and other glycoproteins. Then we have podocytes and their interdigitating foot processes. Podocytes, these are cells that are embedded in and adhere to lamina rara externa of the glomerular basement membrane. And the foot processes are separated by something called filtration slits, which are bridged by a thin slit diaphragm composed of a protein called nephrin. So you have the filtration slits, and these are bridged by a little diaphragm called by a protein called nephrin. Then we have the mesangial cells between the capillaries, and they support the glomerular tuft. Mesangial cells are contractile, and they're capable of proliferation or laying down collagen or other matrix components. And they also can secrete many mediators in response to cytokines and other factors. Now, the filtration system is highly permeable to water and small solutes. The podocytes, the slit diaphragms that we talked about, they're important for the diffusion because they, for plasma proteins and for podocytes themselves, are responsible for the synthesis of glomerular basement membrane. The selective permeability discriminates protein molecules according to size. So the larger, the less permeable, and according to charge. So the more cationic, the more permeable, and also to shape. So this filtration barrier allows only certain molecules to pass through the glomeruli to go into the rest of the structures of the kidney. Now, for the diseases, we first define glomerular diseases, These are defined as a group of diseases that damage the different components of the glomerulus, very self-explanatory. They can be a result of either a systemic disease, and then they're referred to as secondary glomerular diseases, or they can be from primary, or they can be primary in which the kidney is the only predominant organ involved. Most of these are done via immune mechanisms of primary glomerular diseases, and many of the secondary ones are either by deposition of antigen-antibody complexes or by antibodies that react with the glomerulus with the glomerulus's intrinsic antigens or with extrinsic molecules, and they're planted there. So to go more into detail of the general mechanisms of how they work, we have, as you can see, 5 main classifications of their mechanisms. We have glomerular nephritis that is caused by circulating immune complexes. So you have deposition of immune complexes initiates complement-mediated leukocyte activation, and then this causes glomerular injury. Over here on the electron microscope, you have dense immune deposits on one or 3 of locations of the glomeruli. It can be subendothelial, subepithelial, or in the mesangium. We will go later into what diseases cause what. The pattern of the immune complex deposition with immunofluorescence is also granular. So you see the dense spots on electron microscope, and in immunofluorescence, it's granular. Then we have glomerulonephritis, which is caused by immune complexes found in situ. So you have deposition of antibodies against intrinsic or planted antigens in the glomerulus, as it appears in membranous nephropathy, which we will see in a minute. Then we have anti-glomerular basement membrane antibody-mediated glomerular nephritis. So over here, you have deposition of autoantibodies directed against protein components of the glomerular basement membrane itself. Here you see a linear pattern in immunofluorescence microscopy. Then we have glomerular diseases caused by complement activation. Unregulated activation of the complement pathway occurs, and this results in complement-mediated injury. And then we also have non-immune mediated methods of glomerular injury, such as podocyte injury or nephron loss. Podocyte injury can be by toxins, certain cytokines, or antibodies to podocyte antigens. This injury produces morphological changes, including effacement of the foot processes, which means flattening of the foot processes, erasing them, vacuolization, and detachment from the basement membrane. This results in the development of proteinuria. And then we have nephron loss. Once renal diseases destroy sufficient nephrons, affected individuals have proteinuria, and their glomeruli show widespread scarring called glomerulosclerosis. Intact glomeruli undergo hypertrophy to maintain the renal function, which then results in hemodynamic changes, including increase in a single nephron glomerular filtration rate and blood flow. And this finally leads to further endothelial and podocyte damage with segmental or complete sclerosis of the glomeruli. So you always have compensation by some parts of the kidney when other parts of the kidney are not working. Right. So now we go to one of the two main types of glomerular diseases classification, nephrotic syndrome. The other one is going to be called nephritic syndrome, which we will go through later. Now, nephrotic syndrome has many diverse causes and they share a common pathophysiology. You have damage to the capillary wall and the podocytes get disrupted, and this results in increased permeability to plasma proteins due to the impaired charge barrier. Now, the hallmark manifestation of nephrotic syndrome is having massive proteinuria of greater than 3.5 grams per day. These clinical signs, this proteinuria, can be selective of only showing of low molecular weight proteins such as albumin, or non-selective of having more higher molecular weight proteins such as immunoglobulins. Then we also have hypoalbuminemia, which leads to pitting edema, mostly periorbital, and it can also be ascites. There's hyperlipidemia and lipiduria, and this occurs because the liver tries to compensate for the lack of protein by increasing production of lipoproteins. And this is why you get hyperlipidemia and lipiduria. And then you have hypertension because of the decreased intravascular volume due to the decreased oncotic pressure, decreases the GFR, and then this causes an increase, induces the RAS system, which promotes water and salt retention and vasoconstriction, aggravating the edema, and you get generalized edema sometimes called anascara, with vasoconstriction causing hypertension. Then we have a hypercoagulable state as well due to the loss of antithrombin 3, and hypogammaglobulinemia due to loss of immunoglobulins in urine, which then this increases the risk of infections occurring. The pathogenesis of this, it's that podocyte damage, it's really mainly mediated by cytokines and released during the inflammatory reaction, which results in damage to both the charge and the physical barriers, and this causes an increased permeability in to the plasma proteins. Now, we have multiple nephrotic syndrome classified diseases. The first one is minimal change disease, and the name itself can tell you a lot about the disease. So over here, you have diffuse effacement or flattening of the foot processes of the podocytes and the glomeruli, leading to an impaired charge barrier. This is the most common one to occur in children. It can either be idiopathic or secondary to Hodgkin's lymphoma, because this results in a lot of cytokine production from plasma cells. And as it is minimal change, you cannot see it on a light microscope. You can only see it on an electron microscope. So, and over there, you see the effaced foot processes. So how it works exactly is that you don't have any immune complex deposition. The T cells have increased synthesis, produce more cytokines, and they trigger from either idiopathic or Hodgkin's lymphoma. And then this leads to damage to the foot processes of the podocytes, causing them to flatten. And then the glomerular basement membrane loses its negative charge, and you have selective proteinuria, loss of only the charge barrier while the size barrier is still existent. So then the treatment, it has a great prognosis. You just give them corticosteroid therapy. So this is minimal change. Next one we have is focal segmental glomerulosclerosis. Again, the name says a lot about it. So this is glomerulosclerosis, which is scarring of the glomerulus that affects segmentally, only affecting part of the neurons, and focally, only affecting some neurons. There is effacement of the foot processes and hyalinosis in some of the glomerular lobes, but only part of it is affected, right? This is the most common one in adults. It occurs due to an unknown mechanisms. Many mechanisms can cause the epithelial damage, such as genetic factors or circulating cytokines. There can be a genetic mutation of the nephrin protein. And then this, I told you, nephrin was the protein that controls the filtration slit permeability. And then this can cause deposition of hyaline in the glomeruli by entrapment of the plasma proteins and lipids in the foci of injury where sclerosis develops. And then in time, this progresses to global sclerosis of the glomeruli, and you get tubular atrophy and interstitial fibrosis, which can lead to chronic renal failure. But in the mild form, it's only some parts of the nephron, some parts of the glomeruli, and some part of the nephron. Now, again, it can be idiopathic primary, secondary associated with either heroin, HIV, sickle cell, obesity, iatrogenic from interferon treatment, or congenital. In the light microscopy, this one shows on light microscopy, unlike minimal change disease, you have focal and segmented sclerosis and hyalinosis. Immunofluorescence is usually negative, but it can be specific for some stuff. An electron microscope shows diffuse effacement of the foot processes, just like minimal change disease. Clinically, it's variable. It can either heal spontaneously or go to chronic renal failure. You get non-selective proteinuria, and it can occur with hypertension and hematuria. The treatment is usually treated with corticosteroids, but it has an inconsistent response. Thus, when the disease develops to chronic renal failure, thus the disease can develop to chronic renal failure where more and more glomeruli are affected. Next one we have is membranous nephropathy. This is diffuse thickening of the glomerular basement membrane due to deposition of immune complexes or antibodies against antigens in the subepithelial side of the glomerular basement membrane. So if you look at the photo, you have the glomerular basement membrane and the subepithelial side, and you have deposits forming over there in the photo at the top. This is most common in Caucasian adults. It's the number 2 common nephrotic syndrome in adults. The pathogenesis, it can be either primary or secondary, like the rest. You have immunocomplexes that deposit, normally autoantibodies against the phospholipase A2 receptor, which is an antigen on the podocyte. These immune complexes form and they cause inflammation at that area. You have complement getting formed, damaging the capillary walls, and then increasing the protein permeability. Or it can be secondary to some drugs such as NSAIDs or penicillin, infections, syphilis, HPV or HCV, or systemic diseases such as lupus or the solid tumors such as the lung carcinoma or colon carcinoma. And then on the pathology side, on the light microscopy, you have diffused capillary and glomerular basement membrane thickening, while on immunofluorescence, you have granular appearance due to immunocomplex deposition. And then on electron microscope, you have subepithelial deposits that's described to be spike and dome pattern on silver staining with effacement of the foot processes. Clinically, it can progress to chronic renal disease, and it presents with non-selective proteinuria, and it is not responsive to corticosteroid therapy. So that is membranous nephropathy. The next one we have is membranoproliferative glomerulonephritis. This one we have 2 types, actually 3 types, but we normally just talk about those 2 types. It's defined as diffuse thickening of the glomerular basement membrane due to accumulation of immune complexes in the glomerular basement membrane or subendothelially, right? It can either be primary, which has 2 types, or secondary from other diseases. Now in the type 1, the first type is called type 1. It's associated with either hepatitis B or hepatitis C. These antigens, they bind with their antibody and they form immune complexes that deposit in the subendothelial layer. And then this leads to activation of the classical complement pathway, leading to complement and immune complex deposition. It can also be from inappropriate activation of the complement by an autoantibody called the nephritic factor. And this is an IgG that binds to C3 convertase, stabilizing it. Therefore, you have a conversion of C3 and becoming into C3a and C3b constantly. This immune complex or the complement, they deposit subendothelially. They bring inflammatory cells that release oxidants and proteases, and then these oxidants and proteases then damage the capillary wall and induce thickening of the basement membrane and proliferation of the mesangial cells. And then this causes splitting of the basement membrane, which is defined to be a tram track appearance on light microscopy, right? So the splitting of the basement membrane with the proliferation on some parts gives it a thick, nothing, thick, thin type of appearance, giving it looking like a tram track. Then the second one is mostly called dense deposit disease. It's no longer called type 2. This one is very rare. This is associated with increased activity of the C3 nephritic factor, giving persistent complement activation and its deposition in the glomerular basement membrane and intramembranous immune complex depositions. And you also have over here decreased serum C3 because it's constantly becoming C3a and C3b. Thus over here, complement activation is a much bigger role than in the other one. In light microscopy, the way it looks is that the glomeruli are large and they're hypercellular due to the proliferation of the mesangial cells and increased extracellular matrix. They get a lobular appearance of the glomeruli due to the high extracellular matrix. And in type 1, you get a tram track appearance, which is caused by the glomerular basement membrane splitting by the mesangial growth. Immunofluorescence, it's granular, and electron microscopy, you have subendothelial or intramembranous depositions of immune complexes. And then clinically, it can show as nephrotic syndrome or nephritic syndrome, which we will get into more detail later, or even a mixture of both of them. Then we have diabetic glomerulopathy, which is also still nephrotic syndrome. I know it's a lot, but when you get the hang of it, they're very similar and they're quite easy to remember at some point. This is one of the most common stages of end-stage renal disease. The pathogenesis, it's via the formation of advanced glycosylation end products. So the matrix deposition, it can either be uniform in the glomerulus, being diffuse glomerulosclerosis, or it can deposit as nodules called Kimmelstein-Wilson nodules in the mesangium. This thickening of the basement membrane and the depositions of the advanced glycation end products leads to inflammation, making it more permeable and leading to proteinuria. First, you have microalbuminuria, but in later stages, it becomes macroalbuminuria. The mesangium, in response to this high pressure state caused by hyalinosis of the vascular membrane, it starts to deposit more matrix, and this expands the glomerulus. And then the vascular basement membrane, which causes this high pressure state, you mostly have obstruction of the efferent arteriole, and this causes initial hyperfiltration of the kidney. Now, the morphology is that it can either be diffuse or it can be nodular, called Kimmelstein-Wilson nodules, and these are balls of matrix. Macroscopically, the kidneys are shrunken with nodules on their external surface and thinning of the cortex. Clinically, first of all, it's in the beginning, it's asymptomatic, but as more nephrons are damaged, the glomerular filtration rate decreases and it can cause end-stage renal failure, end-stage renal disease. Then we have systemic amyloidosis. I think this should be, if it's not the last one, it's the second to last one. Amyloidosis, we know from other sections of pathology, it's a systemic disease. And the most commonly involved organ in amyloidosis is the kidney. And it's associated with amyloid deposition of both AL amyloid and AA amyloid. It's a secondary glomerulopathy, and on light microscopy, just like any other type of amyloidosis, the Congo red stain shows the apple green birefringence under polarized light in the mesangium, and the immunofluorescence tends to be negative because there's no antibodies involved in this disease. Right, so that was the last of the nephrotic syndrome. Now we have nephritic syndromes. Nephritic syndromes, these syndromes, they're clinical manifestations, right? So nephritic syndrome is the clinical manifestations of inflammation of the glomeruli, and this results in glomerular basement membrane disruption. You have oliguria, hypertension, hematuria, which shows dysmorphic red blood cells and red blood cell casts in the urine, azotemia, and proteinuria, but it is subnephrotic, so it is less than 3.5 grams per day. So the first nephritic syndrome we're going to talk about is acute post-infectious glomerulonephritis. This is a nephritic syndrome that arises after an infection with group A strep on the skin or on the pharynx. It's the most common type of infectious glomerulonephritis that occurs between children of 6 to 10 years old. The pathogenesis of this is that nephrotogenic streptococci induce a type 3 hypersensitivity reaction, and this causes immune complexes deposition in the glomeruli, mostly being subepithelial, and this causes inflammation to occur and damages the podocytes. This damage to the podocytes causes larger molecules to filter through, such as red blood cells, causing hematuria, and proteins, causing proteinuria. The immune complexes also activate the alternative complement pathway, and this causes even bigger damage. Now, how it looks pathologically, on the light microscopy, the most characteristic change is the increased cellularity of the glomerular tufts, and this affects almost all the glomeruli, being diffuse glomerulonephritis. The increased cellularity is caused by proliferation and swelling of the endothelial and the mesangial cells, and by infiltrating the neutrocytes and monocytes. You also have red blood cell casts found in some of the tubules. Then on immunofluorescence, if you look at the photo at the bottom, you can see it's a granular appearance. It is defined as starry sky from IgG, IgM, and C3 deposition along the glomerular basement membrane and the mesangium. And on electron microscope, you have subepithelial immunocomplex humps. Then clinically, it occurs 6 weeks after a pharyngeal infection, after impetigo, and 1 to 2 weeks after the pharyngitis. You have elevated streptococcal titers in the serum, decreased C3 levels because it's consumed with the activation of the complement, peripheral and periorbital edema, Coca-Cola colored urine due to the blood that is in the urine becoming from the hemoglobin, the blood that's in the urine becoming methemoglobin, and also proteinuria. The prognosis of this is that children usually have a complete recovery with supportive treatment. Adults, around 40% of them can develop into chronic renal failure. The ones with diabetes or above 60 are at risk, and it can also lead to cardiac manifestations from due to the retention that occurs and edema. Over here, you should not give steroids because it can actually worsen the state. So that is acute post-infectious glomerulonephritis. Then we have rapidly progressive glomerulonephritis, which is also called crescentic glomerulonephritis. This is a nephritic syndrome that progresses to renal failure in days to weeks. That's why it's called rapidly progressive. And it is characterized by crescent-shaped glomerular deposition, also why it's called crescentic glomerulonephritis. Now, the pathogenesis of it, this one again, we have multiple types, which I will go through in a minute. But the general pathogenesis of it is that you have an immunological attack that leads to glomerular necrosis and inflammation. And this disrupts the glomerular basement membrane. And then because of this disruption and the inflammation, you have accumulation of fibrin in the Bowman's capsule. And then this causes proliferation of the parietal cells of the Bowman's capsule. So the fibrin and the thick layer of the proliferated parietal cells and macrophages and red blood cells, they create these crescents, which can later go through sclerosis, which is replaced by a scar tissue, and obliterate the Bowman's capsule completely. And then this can decrease the GFR and lead to renal failure. Now, for the pathology on light microscopy, you have hypercellularity and crescents that obliterate the Bowman's capsule. And through immunofluorescence, you can divide it into three main types. Type 1 is a linear pattern of deposition. You can see it through the photos on the right. So in this linear pattern of deposition, we can see it in a disease called Goodpasture disease, where you have anti-glomerular basement membrane IgG antibodies. In some patients, these also bind to the pulmonary alveolar capillary basement membrane to produce the pulmonary hemorrhages associated with renal failure. And over here, then it's not called Goodpasture disease, but Goodpasture syndrome. These antibody attacks are in C2 antigens of the basement membrane and deposit in a linear fashion. Clinically, it presents with hematuria and hemoptysis if it's Goodpasture syndrome. So that's type 1. Then type 2, we have a granular pattern of deposition. This can be a result of any immunocomplex deposition disease, resulting in immunocomplexes mostly being in the subendothelial layer. But it can be from, let's say, post-infectious glomerulonephritis, IgA nephropathy, or even due to lupus. This has a granular layer, you can see in the second photo. And then the third one, it's also called post-immune because there's no immunofluorescence, it's completely dark. There's a lack of detectable anti-glomerular basement membrane antibodies or immunocomplexes via electron microscope or immunofluorescence. But most of these patients, they have circulating ANCAs, which are anti-neutrophil cytoplasmic antibodies. They're believed to be related to the systemic vascular diseases that causes these ANCAs to show up. And those include Wegener's granulomatosis, also called granulomatosis with polyangiitis, and these present with C ANCA, or microscopic polyangiitis, which presents with P ANCA. And then on the electron microscope, you have ruptures of the glomerular basement membrane in all three types. So that was rapidly progressive glomerulonephritis. I hope it was a good review. Then we have diffuse proliferative glomerulonephritis, which is the most common and severe subtype of lupus nephritis. So with lupus, there's many types of ways the renal disease can show, but the most severe one, and unfortunately the most common one, is diffuse proliferative glomerulonephritis. This is mainly characterized by its hypercellularity. You have increased mesangial, epithelial, endothelial, and inflammatory cells, where more than half of the glomeruli are affected. These immune complexes are deposited subendothelially and they activate the complement pathway. The pathology of it, you have wire looping of the capillaries, looks like a wire loop. These subendothelial immune complexes deposits, they create thickening of the capillary walls, which gives it the appearance of wires looping. Immunofluorescence is granular, and electron microscopy, you have subendothelial IgGs. Clinically, it can be nephrotic and nephritic syndrome simultaneously. And then we have the next one is IgA nephropathy, also called Berger's disease. The most common nephropathy worldwide, You have IgA and IgG complexes. So complexes of IgA with IgG together in the mesangium, which is due to a defect in the glycosylation of IgA. So the way it works, IgA1, which is a subtype of IgA, this is normally glycosylated in its hinge region. With this glycosylation, the body is able to identify the IgAs. But when too much of it accumulates and degrades it. But in IgA nephropathy, there's abnormal glycosylation of the hinge region, and the body can't recognize it as a self molecule. So then this results in their inability to be degraded, and then you have formation of IgG against the non-self IgA. And these form a complex. This complex travels in the bloodstream and it traps in the mesangium of the kidney. This is the hallmark of IgA nephropathy, the deposition of the IgA in the mesangium. That's the hallmark of it. And then this causes an inflammation to occur, a type 3 hypersensitivity reaction to be exact, giving rise to another inflammatory response. Once the immunocomplexes are deposited, you have activation of the alternative complemented pathway, which leads to glomerular injury, damaging the basement membrane, and then presenting with nephrotic syndrome and hematuria. The trigger for increased IgA can be an infection affecting the mucosal linings, like an infection of the respiratory tract or the GIT. Clinically, you have hematuria with red blood cell casts that occur at the same time of respiratory and GI infections. Another thing that mostly is confused with IgA nephropathy is Henoch-Schönlein purpura, which also shows IgA deposits in the kidney. But that one is more systemic and shows depositions in the skin and joints and other organs, while IgA nephropathy is only limited to the kidneys. Now, the pathology of it is on light microscopy. You have mesangial-proliferation and expansion. On immunofluorescence, you have IgA-based immunocomplex depositions in the mesangium, showing a granular pattern. And on electron microscopy, you have immunocomplexes in the mesangium. Complications include chronic renal failure, and treatment is corticosteroid therapy. Then we have the last nephrotic syndrome, or even the last glomerular diseases, and this is called Alport syndrome. This is an X-linked dominant disease that's from defective or absent collagen type 4 that affects the kidneys, the cochlea, and the eyes. This missing collagen type 4, which is crucial in the basement membrane, makes the basement membrane thinner and split it, making it more permeable. This causes hematuria and proteinuria, and eventually the glomerular basement membrane undergoes sclerosis, and this causes renal failure. On light microscopy, the renal tubular cells, they appear foamy because of the accumulation of fats and polysaccharides. On electron microscopy, it has a basket weave appearance due to alternating areas of thick and thin glomerular basement membrane. And clinically, as it affects the kidneys, the ears, and the cochlea and the eyes, you have glomerulonephritis, sensory neural hearing loss, and lens dislocation, posterior cataracts, or corneal dystrophy. So that was the last nephritic syndrome. So now we continue to another section of this lecture, which is diseases affecting the tubules and the interstitium. So we talked about glomerular diseases, now it's the other part. Now, the first one we're going to talk about is tubulointerstitial nephritis. Tubulointerstitial nephritis is a group of inflammatory kidney diseases that involves the interstitium and the tubules. In the case of this, caused by a bacterial infection, the renal pelvis is mostly involved, and it's then it's called pyelonephritis. Interstitial nephritis is mostly for non-bacterial origin diseases, such as from drugs, metabolic disorders, etc. It can also be divided into acute tubulointerstitial nephritis or chronic, which we will talk about. So the first one we're going to talk about is acute pyelonephritis. This is suppurative inflammation of the kidney and the renal pelvis that is caused by a bacterial infection. It is the most common cause of tubulointerstitial nephritis and more common in females due to the anatomical proximity of the rectum and the urethra and even the shorter urethra. Now, the pathogenesis, there's three main causes. This involves the vesicoureteral reflux with ascending infections. So the incompetence of the orifice, of the vesicoureteral orifice, resulting in reflux. The intravesical portion of the ureter is normally compressed during micturition. So this prevents the reflux of the urine. But in VUR, there's no compression of the vesical portion of the ureter during micturition, and then this causes urine to reflux back into ureters, causing infection that can reach the kidneys. It can also occur due to a congenital effect of the vesicoureteral junction. Then we also have ascending infections. This is the most common one in women. They ascend via the urethra into the bladder, and they cause cystitis and urethritis. And then hematogenous spread, which is not very common, and this is associated mostly with Staphylococcus aureus. We have some risk factors associated with this disease. As I mentioned before, females are more affected than males. Instruments such as indwelling catheters, urinary tract obstructions, such as with benign prostatic hyperplasia. In males, it can arise as that arises in males, or it can be from pregnant women because you get urine stasis in pregnancy due to the pressure on the bladder and the ureters. Or it can just be from urolithiasis, which is stones. Also common in diabetics or patients with neurogenic bladder dysfunction. So you get stasis of the urine in that case. Now, the pathology of it, microscopically, it presents with patchy interstitial suppurative inflammation with neutrophils getting aggregated and tubular necrosis. And macroscopy, you have an enlarged swollen kidney with small yellow abscesses and a hemorrhagic border around them. This can be either in the cortex or the medulla, but it's most likely mainly in the cortex. The clinical features of this, it's fever and flank pain at the costovertebral angle. You have increased frequency and pain during urination, which is called dysuria. Nausea, vomiting, chills, and other systemic diseases can also follow. Complications of this includes pyelonephritis, chronic pyelonephritis, perinephric abscesses, which is expansion of the inflammation to the renal capsule and the perinephric tissue, pyelonephrosis, which is when the abscess in the kidney can't be drained, transforming the kidney into a large sac, which is filled with pus, renal papillary necrosis, which is coagulative necrosis with preservation of the tubular outlines, which can be seen bi or unilaterally, especially in the case of urinary tract obstruction in diabetics, and worstly septicemia and shock, unfortunately. You diagnose this by using laboratory findings that show white blood cell cast in the urine, turbidity of the urine, bacteriuria, and sometimes hematuria. So that's acute pyelonephritis. Then if there's recurrent acute pyelonephritis so many times, it can become chronic pyelonephritis. It can either be from due to two predisposing conditions make it more likely, such as, and these are called chronic obstructive pyelonephritis or chronic reflux pyelonephritis. In chronic obstructive pyelonephritis, the obstruction predisposes the kidney to an infection. So you get recurrent infections superimposed on obstructive lesions, and this leads to recurrent renal inflammation and scarring, and this finally causes chronic pyelonephritis. While in chronic reflux pyelonephritis, this is the most common cause of chronic pyelonephritis. It's from a superimposition of a UTI on a congenital vesicoureteral reflux. and that's present in the bladder. Microscopically, it presents with chronic inflammation and with scarring and uneven fibrosis and tubular atrophy with something called thyroidization, because it looks like the thyroid under the microscope, where you have proteinaceous eosinophilic casts that accumulate in the tubules, and these resemble thyroid follicles. And macroscopically, it can be diffuse or in patches, one kidney or both kidneys affected. They're usually not equally damaged and have uneven scarring. The hallmark of this is scarring that involves the pelvis and the calyces with calyceal deformities. And then clinically, it presents with hypertension. So if a child has hypertension, you should be very concerned about this. And it can lead to chronic renal failure manifested by the loss of ability to concentrate urine due to the loss of the tubular functions. And then over here on the photos, you can actually see how it looks different if it's caused by vesicoureteral reflux or if it is caused by obstructive uropathy. So you only have the top and the bottom in the vesicoureteral reflux, while in obstructive, it's on all sides are affected. Next one, we have tubulointerstitial nephritis. We have drug-induced tubulointerstitial nephritis. The epidemiology of this, to make it easy, we have the 5 Ps. So penicillin, particularly methicillin, P itself, so meaning diuretics, pain-free, representing NSAIDs, proton pump inhibitors, and rifampin. The pathogenesis is that these drugs act as haptens, and what a hapten means is that these are small molecules that if they're attached to a large carrier, such as a protein, they can induce an immune response. So it's a type 2 and a type 4 hypersensitivity reaction. On microscopy, you have edema and infiltration of lymphocytes and macrophages, and eosinophils and neutrophils can also be there. Clinically, fever, rash, hematuria, flank pain, but it can also be asymptomatic. And treatment is to remove the drug that's causing this. Then we have urate nephropathy, which is inflammation of the kidney due to deposition of urate crystals, which can be acute, chronic, or from uric acid stones. If it is acute, you have mostly caused from leukemia or lymphoma after severe chemotherapy, where you have a massive release of purines. This treatment, it kills the tumor cells and the nucleic acids are broken down to produce urate. And then these crystals, they precipitate in the renal tubule and obstruct the nephrons. Then you have chronic urate nephropathy, which is caused by gout. And these are patients with long-standing hyperuricemia. This urate accumulates in the ducts and interstitium, forming needle-like crystals, around which you have granulomatous inflammation. And the nephrolithiasis is just uric acid stones. And then we have multiple myeloma kidney, which is also called light chain cast nephropathy. This is damage to the kidney in those who have multiple myeloma. There's 3 mechanisms of how this can occur, either by Bence-Jones proteinuria, nephrocalcinosis, or primary amyloidosis. It occurs mostly in most patients of multiple myeloma. For the Bence-Jones proteinuria, the light chains are toxic to the renal tubular epithelium, and they form a cast that obstruct the tubules and initiate a reaction against this foreign body. The body sees it as foreign, so it initiates a reaction forming giant cells in the tubules and the interstitium, and this eventually leads to renal failure. Then we have nephrocalcinosis, which are lytic bone lesions leading to hypercalcemia, calcifying the basement membrane of the collecting tubules, which then leads to polyuria and renal failure. And then primary amyloidosis, where the light chains are converted into AL amyloid, and this causes nephrotic syndrome. And then, so that was the last of our tubulointerstitial nephritis. Now, some other diseases that can affect the tubules and the interstitium, we have acute tubular injury or acute tubular necrosis, and this can be ischemic or nephrotoxic. So for the ischemic, what does acute tubular necrosis even mean in the beginning? It is injury or necrosis to the tubular epithelial cells that can lead to acute renal failure. Now, if it is ischemic, it can lead to decreased blood supply. It can be due to decreased blood supply that results in necrosis of the tubules. If it is secondary to pre-renal failure, it can be from either absolute loss that occurs in bleeding, vomiting, burns, or relative loss, such as in distributive shock, or even congestive heart failure, where you have pooling of the blood in the veins. And then this ischemia may also result from reduced intrarenal blood flow, such as in malignant hypertension, microscopic polyangiitis, a renal artery stenosis, or just blockage by an emboline. So that's the etiology of ischemic acute tubular injury. And then for nephrotoxic, it can be caused by a variety of different chemicals, such as an antibiotic called aminoglycoside, heavy metals, lead and mercury, myoglobin from crush injuries, ethylene glycol, which is an antifreeze material that has a sweet taste. So this is actually the most common cause of acute tubular necrosis in children. Radio contrast dye, even sometimes, and uric acid, which is a waste product of purine degradation, typical in cancer treatment, causing the tumor lysis syndrome, similar to the this one we were talking about, urate nephropathy. Now, if we want to talk for this one again, for nephrotoxic acute tubular injury, or just general acute tubular injury, the proximal tubular cells are very sensitive to hypoxemia, and they're vulnerable to toxins. The dying cells, they shed into the tubules and they cause it to plug, and then you have a buildup of pressure right before the plug. This leads to decreased GFR due to the increased pressure at the top, and less urine is produced, eventually leading to oliguria, azotemia, and uricemia. And because of this lack of filtration occurring, you also get buildup of potassium and acids, causing hyperkalemia and metabolic acidosis. And then sometimes you can also see these tubular casts being shed in the urine, which are brown granular casts. But if the causative agent is removed, then in 5 to 6 weeks, the tubular cells can regenerate. Now, more detail about acute tubular injury or acute tubular necrosis. On pathologically, microscopically, you have enlarged swollen kidneys with a pale cortex and a dark medulla, while microscopically, it presents with tubular necrosis, detachment from the basement membrane, and slowing of the cells and the brown granular cast formation. Which I mentioned before, is found in the urine. And also you can find interstitial edema. Now, between ischemic and nephrotoxic acute tubular injury, in ischemic, it mostly involves the proximal and the thick ascending tubules, and it is characterized by a skip pattern of necrosis. So one part is necrosized, one part isn't, one part is, one part isn't, one part is. You also have detachment of the cells, of the tubular cells from their basement membrane, and they're slowing off into the urine, impairing epithelial regeneration, and also proteinaceous cast composed of a protein called horsefall protein with hemoglobin and other plasma proteins are found in the urine. While in nephrotoxic, the proximal tubules is more prominent, not like ischemic, which has the thick ascending ones. And it's a continued pattern, not a skip pattern of necrosis. The tubular basement membrane is spared, unlike the ischemic one, where you have detachment of the tubular cells from the basement membrane and slowing into the urine. So due to the tubular basement membrane being spared, you have a better chance of regeneration and nephrotoxic acute tubular injury. The diagnosis is through seeing if the casts are visible in the urine, the lab values, and just general symptoms. Treatment, you can perform dialysis. It's usually reversible, but you need to make sure the electrolyte balances are in the safe zone, so supportive treatment. And it takes 2 to 3 weeks for the tubular cells to enter the cell cycle and regenerate. And obviously, if it is for nephrotoxic, you have to remove the offending agents as soon as possible. Now, that was about diseases affecting the tubules and the interstitium. Next, after that, we're going to go into acid-base balance disturbances and electrolyte disturbances. But before that, I just want to talk about hydronephrosis for a minute, because I think this is a very important concept. Hydronephrosis is the dilation of the renal pelvis and calyces. And accompanies, and this is accompanied by the atrophy of the parenchyma, which causes obstruction to the outflow of urine. This obstruction to the renal papillae, calyces, or pelvis, they put pressure on the wall and leads to their dilation. If the dilation is just in the ureter, it's called hydroureter. But if it goes upwards to the kidney, and it can cause hydronephrosis. It's usually unilateral. Bilateral is when the obstruction is below the level of the ureters. Now, the causes of this, it can either be in children, it's mostly congenital, it can be unknown, or from the ureteropelvic junction obstruction, the vesicoureteral reflux, which we talked about before, a ureterocele, which is a soft tissue in the distal ureter that blocks the flow of urine into the bladder, or posterior ureteral valves, which is malformation of the posterior ureter, where a flap of tissue obstructs the flow of urine. Now, in adults, it can be from a foreign body, such as stones. It can be a proliferative lesion, such as in a tumor or BPH, inflammatory lesions from like fibrosis, neurogenic from spinal cord damage, or even pregnancy. And due to the high pressure that is generated in the pelvis, as well as that's transmitted to the collecting ducts and everything, you have compression of the renal vasculature that occurs. And this can lead to arterial insufficiency and venous stasis. The most severe type affects the papillae, which have the greatest increase in pressure. Then the initial function disturbances are mostly tubular, and you have disturbances in the concentrating ability of the kidneys. The obstruction can also trigger interstitial inflammation, which can lead to interstitial fibrosis. Therefore, microscopically, you have an enlarged kidney with dilated ureter and a dilated ureter and renal pelvis, compression atrophy at the cortex and medulla, while microscopically, you can have inflammation occurring. Clinical features, if it's bilateral, it can cause anuria, while unilateral can be silent for so long and you can't even know it, and it can be an incidental finding sometimes even. Complications, it can lead to renal atrophy, azotemia, hypertension, and the best way to relieve it is to remove the obstruction that's causing this. So that's about hydronephrosis. Now we're going to talk about the acid-base balance disturbances and some electrolyte disturbances as well, such as calcium, phosphate, potassium, and magnesium. But for now, development of metabolic alkalosis, which means there's more alkaline in your blood than acids. So you have a higher pH in your blood than usual. It can occur in hypokalemia, where you have an increased, in hypokalemia, there is an increased gradient for potassium because there's less outside and there's the same amount, so the gradient between the two is increased, leading to hyperpolarization, and this drives more bicarbonate from the cell. This increased bicarb efflux from the proximal renal tubules via the sodium bicarb co-transport can cause intracellular acidosis, and then this stimulates the sodium-hydrogen exchange. Therefore, it promotes hydrogen excretion and bicarbonate production in the proximal tubule, and this leads to alkalosis. Other causes of alkalosis involves vomiting of the stomach contents because the body loses hydrogen and what's left behind is bicarbonate, which is produced when the HCl is secreted in the parietal cells. Normally, the bicarbonate formed in the stomach is reused in the duodenum to neutralize the acidic stomach contents, and only transiently, and this only weakly leads to alkalosis. It can also be from reduced blood volume because this stimulates the sodium-hydrogen exchange in the proximal tubules, and it forces increased bicarbonate reabsorption by the kidneys. In addition, aldosterone is also released in hypovolemia, stimulating the hydrogen secretion in the distal nephron. Thus, the kidney's ability to eliminate bicarbonate is compromised, and then you get volume depletion alkalosis. Hyperaldosteronism, therefore, can lead to alkalosis. There's also hypoparathyroidism because the parathyroid hormone normally inhibits the bicarbonate absorption in the proximal tubules. And then in liver failure, because the hepatic production of urea is decreased, the liver uses less bicarbonate and alkalosis develops. However, in liver failure, it's mostly respiratory alkalosis as a result of the damage to the respiratory neurons. And then you also have increased supply of alkaline salts and consumption of the organic acids that can occur and cause metabolic alkalosis. Then we have the next one is metabolic acidosis. So the complete opposite. While the other one was hypokalemia, this is hyperkalemia. In hyperkalemia, the chemical gradient is reduced. So instead of hyperpolarization, you have depolarization, which reduces the driving force of bicarbonate out of the cell, slowing down the efflux of bicarbonate in the proximal tubules through the transport. And then the resulting alkalosis inhibits, the resulting intracellular alkalosis inhibits the luminal sodium-hydrogen exchange and impairs the hydrogen secretion as well as the bicarbonate production in the proximal tubule cells, leading to acidosis. So it's the complete opposite of what we just mentioned for alkalosis. Other causes of this include renal failure, transport defects in the renal tubules, hypoaldosteronism because aldosterone normally stimulates hydrogen secretion in the distal tubules, hyperparathyroidism because parathyroid inhibits the bicarb absorption in the proximal tubules. Thus, if it's high, the renal excretion of bicarbonate is increased, and parathyroid hormone promotes also the mobilization of alkaline materials from bones. So acidosis doesn't really occur because of this mobilization from bones. The massive loss of bicarbonate occurs only if carbonic anhydrase is also inhibited, which is an enzyme in the kidney, because that activity is a precondition for bicarbonate absorption in the proximal tubules. Now, in certain, it can also be due to vomiting of intestinal contents, diarrhea or fistulas. Infusion of large amounts of sodium chloride can lead to acidosis because extracellular bicarbonate is diluted in this way, and also the expansion of the extracellular space inhibits the sodium-hydrogen exchange in the proximal tubules as a result of which not only sodium absorption in the proximal tubules, but also hydrogen secretion and bicarbonate absorption is impaired. And we also have infusion of calcium chloride because this results in the deposition of calcium in the bone in the form of alkaline salts. Hydrogen ions are then formed from this when the bicarbonate and phosphate dissociate, causing acidosis. It can also be from mineralization of bone or increased formation or decreased breakdown of organic acids. So that's acid-base disturbances. And to roughly go through electrolyte disorders, such as potassium imbalance, the secretion of potassium in exchange for sodium in the distal tubule and collecting duct is the decisive step in determining how much potassium is eliminated. Therefore, abnormal potassium balance can occur in inadequate potassium supply or extensive renal elimination of potassium, such as hyperaldosteronism or increased sodium in the distal tubules. Now, abnormal potassium balance can also occur in inadequate potassium supply, in alkalosis, fewer hydrogen ions are secreted in the tubules and the collecting duct, and more potassium is lost. While in acidosis, well, we mentioned decreased potassium secretion in the distal nephron occurs. Potassium may be lost via the gut, but if there is an increased supply of sodium or in hyperaldosteronism, an increased amount of sodium is similarly absorbed in the colon in exchange for potassium. Even minor shifts of potassium between intra and extracellular fluid can lead to massive changes in the plasma potassium concentration, because the potassium content in the cell is more than 30 times than that in the extracellular space. And we already talked about how in acidosis and alkalosis this can occur, while in insulin deficiency or in hypoglycemia when you're fasting, the cells lose potassium. And the administration of insulin in diabetic hyperglycemia or food intake by a starving person may lead to hypokalemia because the cells will be taking up the potassium. And then catecholamines, they also promote the uptake of potassium by the cells via the beta receptors and the cellular release of potassium of cells via the alpha receptor. The effects of lack of potassium, it induces cellular retention of hydrogen and its secretion from distal tubules, alkalosis and polyuria, and eventually irreversible tubular damage. And then abnormalities of magnesium. Magnesium deficiency is when there's inadequate supply or there's a great loss via the gut or the kidneys. Magnesium is mainly reabsorbed via the ascending loop of Henle. The reabsorption is paracellularly through the tight junctions, and this is driven by the transepithelial potential caused by the sodium chloride resorption. This potential is reduced in hypercalcemia and alkalosis, which can lead to magnesium in the urine. The sodium chloride absorption and thus the transepithelial potential are increased by ADH. However, ADH is decreased in alcoholism, and then therefore in alcoholics, the resorption of sodium chloride and magnesium falls. And the reabsorption of magnesium is also reduced in salt-losing nephropathy, osmotic diuresis, such as it occurs in diabetics, or due to loop diuretics and hyperaldosteronism. Hyperaldosteronism, it's probably via the volume expansion, which reduces the sodium and magnesium resorption in the proximal tubules and the ascending limb. We also have shifts of magnesium between the intra and the extracellular spaces, which can change the plasma concentration of magnesium, such as it occurring in diabetics or in fasting people, because insulin stimulates the uptake of both potassium and magnesium, so the loss of magnesium may occur in diabetics or prolonged fasting. Substitution of insulin or resumption of food intake may then bring about hypomagnesemia. And then we have, it can also be occurring in patients with acute pancreatitis, decreasing in ionic magnesium, because the enzymes of the pancreas can destroy the magnesium ions. The effects of like the clinical symptoms of both magnesium excess and deficiency And the excess, it's you have impaired neuromuscular excitability, so hyporeflexia that can lead to even respiratory arrest, disorders of cardiac action potential, and vomiting. And then if magnesium is deficient, it leads to the opposite. So neuromuscular excitability, hyperreflexia, and cramps. For magnesium excess, sometimes it can be caused by renal failure. If the glomerular filtration rate is reduced, magnesium excretion can be maintained by a reduction in reabsorption. But if it falls, if the glomerular filtration rate falls below a certain number, then it can no longer be compensated by the absorption, and therefore you get hypermagnesemia. Next, we have calcium. So the regulation of extracellular calcium concentration is mostly the task of the parathyroid hormone. It's normally released in hypocalcemia, and its actions is to increase the calcium concentration. It stimulates the mobilization of calcium phosphate from the bone, decreasing the plasma concentration of phosphate by inhibiting its renal absorption, and stimulating the formation of calcitriol, which promotes the absorption of calcium and phosphate. Thus, it helps with the mineralization of the bones. Now, hypocalcemia itself can be from hypoparathyroidism, vitamin D deficiency, renal failure, or hypomagnesemia. In renal failure, the phosphate elimination by the kidneys is reduced. Therefore, the plasma phosphate level rises, and the calcium phosphate is then deposited in the body. This is one of the consequences of this is one of the consequences of renal failure. Now, even when the total calcium concentration is normal, the concentration of the effective ionized calcium may be reduced because of its formation with proteins or bicarbonate that occurs in alkalosis, or complexes with phosphate due to renal failure. And then we have hypercalcemia that can occur in the opposite. So hyperparathyroidism, vitamin E excess, vitamin D excess, malignant tumors with bone metastasis, and increased enteric absorption due to excessive supply. Now, the clinical symptoms of hypocalcemia, you have increased excitability of muscles and nerves, which are with the occurrence of involuntary muscle spasms called tetany and paresthesia, while the effects of hypercalcemia, it's mostly asymptomatic, but it can present with GI symptoms such as peptic ulcers, polyuria, or increased thirst with polydipsia, or even some psychogenic disorders. And then finally, we have the last slide of the day, which is the abnormalities of phosphate. Parathyroid hormone and calcitriol are essential for the regulation of the phosphate balance. When the kidney function is normal, parathyroid hormone reduces the plasma phosphate level by inhibiting the renal absorption. But at the same time, it promotes the mobilization of phosphate in the bone. And calcitriol raises the plasma phosphate level by stimulating its enteric absorption and renal absorption. Abnormal phosphate metabolism can also be just due to an uneven balance of the distribution of phosphate. Now, the phosphate deficiency can be from reduced enteric absorption, such as in alcoholics or malabsorption, vitamin D deficiency, chronic intake of phosphate binding aluminum hydroxide, or renal loss of phosphate in hyperparathyroidism or certain transport defects, such as Fanconi syndrome. While phosphate excess can be due to increased intake of it, or increased vitamin D, or decreased renal elimination from renal failure or hypoparathyroidism. Now, the phosphate concentration is a lot higher in cells than it is in the extracellular space. That's why the shift between the intra and the extracellular space is very important. The increased uptake in cells occurs after a food intake by starving people and alcoholics, or after insulin administration in diabetic coma and in severe alkalosis. while phosphate is released from cells in acidosis, diabetic coma, and a cell damage. Lastly, an excess of phosphate can also occur from its mobilization from bone, unless its renal elimination is stimulated at the same time. In renal failure or skeletal demineralization stimulated by hyperparathyroidism, this can lead to hyperphosphatemia, as I mentioned before. Now, the clinical effects of both hypo and hyperphosphatemia, they differ, obviously, because there are different levels of the same hormone. But for hypophosphatemia, it depends on the duration and the extent of how long it's been low. But some symptoms include myopathy, such as muscular weakness, a heart failure, hemolysis, nervous system dysfunction, such as convulsions or coma. While hyperphosphatemia, it includes precipitation of calcium phosphate with the development of soft tissue calcification in tissues of low metabolic turnover, such as in joints or skin. And other symptoms include such as itching, known as pruritus, arthritis, even more. It goes on for many other symptoms. And yeah, that is it. So that concludes my presentation on kidney pathology. I hope you enjoyed it and it gave you a good rapid review of this part of pathology of kidneys. If you want to form a feedback, I'm always open to constructive criticism. Please fill out please scan the QR code at the bottom. And yeah, hope you guys enjoyed this lecture. Hopefully I will see you all soon.